To our webinar. This afternoon's webinar is the second educational webinar from the New Jersey Department of Health ICAR team. It is entitled Antibiotic Stewardship in Long-Term Care. My name is Carol Janice, and I'm one of the part-time infection preventionists with the department's ICAR team. I will serve as today's moderator and second speaker. During this webinar, our speakers are going to discuss antibiotic resistance, stewardship in long-term care settings, the challenges in instituting programs, and how our three participating facilities got started. We will emphasize the importance of antibiotic stewardship programs and provide you with resources and realistic approaches for implementation of your own programs. At first, antibiotic stewardship appears to be a daunting task. However, with a supportive and involved multidisciplinary team and one or more of the best practice guidance documents to follow, it becomes remarkably feasible. The next hour will help you define your role in the development and the implementation of an antibiotic stewardship program in your facility and antibiotic stewardship activities. For all of us are involved, whether we be administrators, infection preventionists, direct patient care providers, ancillary or contract employees, medical directors, or other antibiotic prescribers, and more importantly, residents and their families. It is indeed a team sport. Therefore, after listening to of your program. Besides myself, our speakers today will include Patricia Barrett, the Department of Health Antimicrobial Resistance Coordinator, Kathleen Larvison of Meadowview Nursing and Rehabilitation Center, Catherine Van Buskirk and Grace Brunner from the Reformed Church Home, and Linda Parry from Van Dyke Healthcare. Their email addresses are included here, so please consider these individuals and then we're going to hear from our three long-term care facility partners. They'll tell us how they got started and began implementing their programs. Following that, we'll briefly discuss available resources and share them with you via email. Whether you are in the early stages of implementing your program or nearing completion, we hope that you will find these resources helpful. In the last few minutes, we'll respond to your questions. Don't forget to include your questions in the chat box on the right of your screen. Any questions that we cannot answer during the webinar will be answered and shared with everyone via email following the webinar. Let me introduce Patricia Barrett. As part of Patty's role here at the department as our antimicrobial resistance coordinator, she helps develop and promote antimicrobial stewardship projects to prevent the emergence of new multi-drug resistant organisms. Some of you may have already worked with her or received materials from her. Patty?
Thanks, Carol, and hi, everybody. Like Carol said, I am the AR coordinator for New Jersey, which means that I'm really fortunate to work with both the prevention side of activities like antibiotic stewardship in partnership with the ICAR team, as well as the response side, where I work as part of a group of EPIs who I work to identify and contain some really nasty drug-resistant organisms. Now, I realize that many of you may be pretty comfortable and well-versed in the concepts of resistance and laboratory testing, but I want to briefly review some of the important basics that everyone should know regardless of their background or their role within a stewardship program. So just to start off, I want to give some basic terms for your reference. Of course, we do have antimicrobials, which is an umbrella for all types of agents that inhibit or kill microbes. Specifically, we have antibiotics and antifungals, which are the common types of antimicrobials seen in long-term care facilities. Other antimicrobials would be antivirals and antimalarials. I would also like to remind folks, if they are on the line, to please mute, and we'll get to questions at the end of the session. Thank you. So moving on, we do have antibiotic and antimicrobial resistance, which are pretty common terms that are used interchangeably. But please keep in mind that a facility's program should not be limited to stewardship and just antibiotic use. Antifungals are also going to be an important set of drugs that could be preserved and protected. For example, when looking at asymptomatic UTIs that don't require treatment, those could be inappropriately treated at times with antifungals or antibiotics, and so considering both is a helpful piece of stewardship. And of course, antibiotic resistance describes an organism's resistance to an agent that was once effective against it. Some organisms do have intrinsic resistance to certain antimicrobials, but others can develop resistance over time once exposed as well. Usually in literature or in passing, we use terms such as MDR or MDRO, standing for multi-drug resistant organisms. But we do have increasing concern and unfortunately more common see abbreviations such as XDR for extensively drug resistant, as well as PDR for pan-drug resistant. Hopefully these don't become more common, but they are used today. Now, I won't be going over this slide in detail, but I did want to include it as a useful reference for seeing how bacterial resistance can occur. There's lots of great resources out there where you can learn more about resistant threats and on the CDC's website. Now, of course, it's undeniable that antibiotic resistance occurs and affects us all in healthcare facilities. And unfortunately, everyone who uses antibiotics contributes to resistance. But through the lens of stewardship, there are some clear ways that we can check and assess the appropriateness of antibiotic use to ensure that we're not unnecessarily promoting resistance. First, we want to look at the drug. Of course, if antibiotics are not needed, then prescribing them could give space for resistant organisms to thrive or other organisms that are related, such as Clostridium difficile, and those might have the opportunity to flourish and actually cause infection. Otherwise, if the treatment itself is not appropriate, then therapies may not work as effectively as possible. That can vary depending on the infection site, the organism being treated, or the resistance pattern of the organism. Also considering the dose, you want to ask if the strength is appropriate for the body system or organism, as well as the duration to ensure that the time used is appropriate to kill off even the strongest of the organism causing the infection. And finally, the route. We want to evaluate if IV antibiotics, for example, are really necessary if there are other options that are just as effective, such as oral prescriptions. But I do want to stay away from generalizations about drug resistance because resistance can be measured and tracked, and it should be as well. Resistance is most often determined by susceptibility testing. Antimicrobial susceptibility testing, often abbreviated as AST, is usually patient and organism specific, meaning that these values only show us how well we would expect the tested antimicrobial to work against the organism isolated from a specific patient specimen. And with ASTs, results are usually included with interpretations of S, I, or R for susceptible, intermediate, or resistant. But it's important to keep in mind that different laboratories may interpret results in different ways, and some may not provide interpretations at all. So talking to your lab is an important piece of understanding AST reports. Antibiotic therapies should be reassessed after these results come in. If the current antibiotic therapy is listed as one as resistant, for example, the provider should reassess their treatments and see if there are more effective antibiotics that could be used. Other facilities might use different names for these reports, such as CNS for culture and sensitivity, or AFST when looking at antifungal susceptibility. But depending on the methods, AST reports could take 3 or more days to complete. But they are still valuable tools to ensure that the right antibiotics are useful for treatment, especially when a patient isn't responding to the initial treatment options chosen. Other helpful tests that can indicate specific resistance genes or types, such as ESBL or carbapenemase production, can help identify the best drugs for treatment in other cases. But I do also want to zoom out because we can also summarize and monitor antimicrobial resistance on a facility or unit level. This is most often done by using antibiograms. Antibiograms are facility-specific summaries of the antibiotic susceptibility testing from specimens collected over a certain period of time, for example, a year. They're usually presented as a table of organisms or antibiotics, with the values in the cells indicating the % of the organism that was susceptible to a drug, meaning that the higher the value in the cell, the more often the drug was effective against the specific organism. Antibiograms can be used as a tool for prescribing before susceptibility reports come back. And some facilities choose to print out pocket antibiogram cards so that providers can reference their regional or facility resistance patterns when choosing an antibiotic therapy. Facilities that share a lot of patients can also consider sharing antibiograms with other facilities to improve the awareness of resistance in the region. And these antibiograms are also helpful tools for monitoring resistance in a facility over time. In some studies, healthcare facilities have reported that their antibiograms indicate less resistance after instituting a stewardship program, which is great to hear. But keep in mind that antibiograms are not only for hospitals. Laboratories should be able to generate an antibiogram for long-term care facilities upon request, and some may automatically create one as an annual report for facilities. So don't hesitate to reach out to your own laboratory and ask for this information. But to put this all in perspective, we of course want to monitor resistance at both the patient and facility level and implement these stewardship programs because there are true consequences to antibiotic resistance. For example, some treatments are less effective for resistant infections, so finding the right one can take more time. And in some cases, if antibiotics needed are rare or uncommon, they might not be readily available in the facility or even nationally. Also, patients with antibiotic resistance are more likely to require surgery than those without infections, and complications can lead to additional hospitalizations and additional burdens on the patient. In terms of cost, a 2015 article estimated that the U.S. economic burden of resistant infections to be at $20 billion in medical costs per year and an additional $35 billion in lost productivity per year. That's $55 billion every year that takes a toll on the U.S. economy. And of course, these resistant infections and their complications can be very deadly. In 2011, the CDC estimated around 20,000 deaths per year, but that may be a severe underestimated according to more recent articles regarding the lives lost to antibiotic-resistant infections. So even though I've only been with New Jersey for about 2 years now, in that time, I've seen the emergence of multiple new drug-resistant threats in the United States and in New Jersey specifically, which I think makes today's webinar all the more timely and important. Resistant organisms, like some of the ones listed on here, have been identified in New Jersey in the past 2 years, including Candida auris, an organism that primarily affects immunocompromised patients, such as those in long-term care and long-term acute care facilities, as well as those who've had a history of antimicrobial therapy. So inappropriately prescribing antibiotics could unfortunately put some patients at risk for some of these nasty infections. But that being said, with all of your teams developing and learning about stewardship programs, I am really hopeful that we can ensure the emergence of other drug-resistant organisms can be prevented or at least delayed. And with these programs, we can prevent deaths, reduce costs, and treat our patients safely. Thank you for your time.
Thank you, Patty. I'm going to now introduce antibiotic stewardship concepts and share a few recommendations as well as our ICAR findings related to antibiotic stewardship from the 27 long-term care facility assessments that we have performed. All antibiotic stewardship definitions address antibiotic prescribing and prescribing outcomes. CDC defines antibiotic stewardship as a set of commitments and actions designed to optimize the treatment of infections. And I just want to take a second. That's the key word here, and infers ensuring that there is a proper diagnosis, while reducing adverse events associated with antibiotic use. Additionally, the CDC told us that antibiotics are among the most frequently prescribed medications in nursing homes, with up to 70% of residents receiving one or more courses of antibiotics each year. And one statistic that I find very hard to believe is that up to 75% of prescribed antibiotics are either unnecessary or inappropriately used, meaning that the prescribing was of the wrong involved antibiotic, or if it was the correct antibiotic, it was used in the wrong dosage or for the wrong duration. Infection prevention is patient safety, and therefore antibiotic stewardship plays a key role in protecting your residents and elders. Antibiotic overuse is related to some of those adverse events mentioned in CDC's definition. This overuse may increase a resident's risk of C. difficile or an adverse drug reaction, such as an allergic reaction, or maybe it's a drug interaction, or it could be colonization and or infection of an antibiotic-resistant or multi-drug-resistant organism. Two of the most important guiding documents on antibiotic stewardship programs, and for you to review, have come from CMS, the Centers for Medicare and Medicaid Services, and from CDC's HCPAC, Healthcare Infection Control Practices Advisory Committee. In September of last year, CMS released a mandate that includes full development of an antibiotic stewardship program by November this year. The intent of this regulation is clear: ensure appropriate antibiotics are prescribed and that this occurs only when needed with the diagnosis of an infection. And HCPAC released a statement regarding the development of stewardship programs, emphasizing the importance of antibiotic stewardship as a worldwide public health problem and outlining the critical responsibility of all prescribers to incorporate stewardship into their practice and guidelines for treatment. To address the development of stewardship programs, CDC introduced this guidance and checklist, which offers a step-by-step guide to implementation. How you use the guide is going to vary depending upon your availability of staffing and resources within your facility. Our three facility speakers today have utilized this document to develop their programs. They each emphasized to me that the key to getting started and getting a stewardship program implemented is to work in a stepwise fashion, one strategy or one activity at a time. Any step to improve antibiotic use in a long-term care facility is expected to reduce adverse events, prevent the emergence of antibiotic resistance, and lead to better outcomes for your residents. Because of the 1-hour time constraint and the involved discussion necessary for tracking and reporting, today's webinar will only be able to address 5 of these 7 core elements. Those would be the first 4 and the last one, education. The whats and the how-tos of tracking and reporting we felt should be handled separately. As you will see when I share some of the results of our ICAR findings related to antibiotic stewardship, many of the long-term care facilities that we visited are still working on these two elements. All long-term care infection preventionists are comfortable with tracking and reporting information related to healthcare-associated infections. And having this expertise, I'm sure, are willing to help work with prescribing data and prescribing outcomes. However, all of the metrics related to antibiotic usage have been reported to long-term care facilities from their pharmacy consultants as a bottom line usage function. And antibiotic information from their microbiology lab is reported in an antibiogram, noting susceptibility or resistance as Patty showed you. These reports are not in the format of a process or outcome measure as suggested by CDC here. And more importantly, they are not in a feedback format to influence change in prescribing practice among your prescribers. And lastly, nor are they in a format that can reinforce frontline nursing staff's successful involvement in this part of their residents' medical care, ensuring antibiotics are only prescribed for appropriate diagnoses of infection. Nevertheless, a number of the resources that we share with you after this webinar will suggest prescribing policies and interventions, and with them, the corresponding monitoring criteria. Additionally, you will hear our long-term care partners today emphasize McGear criteria and the SBAR. Certainly, these are elements that can be tracked and reported on. ICAR is a CDC-supported national initiative to evaluate the completeness and effectiveness of infection prevention programs across the healthcare continuum. During our assessment visits, as all states and jurisdictions do, we utilize a common tool developed by CDC, and it asks a range of questions focused on several infection prevention domains. For example, hand hygiene, injection safety, sterilization and disinfection, and certainly antibiotic stewardship. This tool is a written question guide, and it is available for you to review on the CDC website. New Jersey's ICAR team has visited 95 healthcare facilities, including dialysis centers, outpatient clinics, acute care hospitals, and long-term care facilities. For stewardship, as you can see, the tool asks questions that parallel the CDC core elements. For example, one of the core elements asks about a leadership commitment, which is echoed in the ICAR tool. So this is our first poll question. Please register your answer, and we will let you know what the results are in a few minutes. Okay, we're going to close the poll question, and at this time, the results show that 70% of our approximate 150 attendees answered yes, showing that they have had some element of a written approved policy started. This slide presents the findings on the progress with AS programs in the 27 long-term care facilities that we visited. We've divided the facilities by those less than 100 beds and those equal to or greater than 100 beds. And you can see that there is a little bit, but really it's fairly minor differences in percentages. Most facilities have begun to review the CDC core elements and are in various stages of implementation. We've highlighted 3 areas with those green boxes with the highest percent adherence to recommended practices. So as you can see, New Jersey's long-term care facilities have impressive leadership support, associations with individuals with antibiotic prescribing expertise, and are aware of report tracking facilities' antibiotic usage. Though most that we visited have not started monitoring this report in association with newly implemented stewardship activities. The other areas are obviously still a work in progress. Let's review the subject matter for each one of these questions for a bit. For leadership, do you have a letter, some formal statement from administration, something that outlines the facility's expectations? And have you identified an individual who is going to be accountable for the program? Somebody that's empowered with this responsibility, possibly the medical director, or maybe the DON. Do you have an infectious disease physician or a pharmacist with special training available? Or have you partnered with the Antibiotic Stewardship Program leaders at your local hospital? Or is there an involved infectious disease physician interested in working with you in your community? Do you have written policies? Have you approved a policy? Policies that are geared to changing prescribing practices and improving antibiotic use? Do you include and outline within them the accountability and responsibility of all elements of the program? Maybe those elements include signs and symptoms that are observed, or reviewing culture data, performing antibiotic timeouts, or monitoring Clostridium difficile rates. Have you implemented any practices? These would be coming from those policies that you have developed. And does your facility have a report from your pharmacy on antibiotic use for the past 6 months? And also a report from your laboratory on antibiotic resistance within the last 24 months. Do you have prescribers? Have you given them feedback, either formally or informally, on their antibiotic use? You can see from this chart that less than 1 in 5 of those that we visited have been able to start this. And lastly, but certainly not least, have you trained nursing staff and clinical providers not only on antibiotic stewardship, but on your specific program implementation? You could do this face-to-face. You could do it in seminars or newsletters or even email blasts. And we're getting close to where about 25% of all of our facilities have started that or have accomplished that. Of the 27 facilities that we visited, only 1 had no gaps. And that was one that we did recently. The remaining, or 96%, have had at least 1 gap in their programs, and often 4 or 5. These figures may be applicable to your facility, so know that you are not alone. And more than that, this is not just descriptive of New Jersey. There are very similar figures that we see with CDC's national data. Using these core elements as a guide, we're going to hear from our 3 partnering long-term care speakers as they address the elements, except for tracking and reporting. Our partners, Kathleen, Grace, and Lynn, are going to share their plans and implementation with you. Some approaches are going to be identical or very similar to each other, and yet each facility you will see is unique. Each facility speaker will identify herself as well as introduce her facility and briefly explain how they got started. The first person to speak this morning will be Lynn Apari from Van Dyke Healthcare. Lynn?
Thank you, Carol. Good afternoon. My name is Lynn Apari, and I am the infection preventionist at Van Dyke Healthcare in Bergen County. Like many of you, I wear many hats. In addition to infection prevention, I serve as the employee health nurse, workman's compensation coordinator, staff development, and some QAs. I am lucky if I can regularly devote 10 hours to infection prevention issues and responsibilities each week. My facility is one of 2 Van Dyke facilities delivering long-term and subacute care. We are the smallest partner speaking with you today. However, our acuity is high with 2/3 of our beds subacute. Van Dyke is a family-owned business, and the family and the corporate offices are supportive and involved in ensuring the best care for our residents. Our medical director embodies this approach and attitude. He has always been very proactive. For many years, he has taken steps to limit psychoactive drug usage and ensure that staff are educated on pertinent, timely issues and advances in care. My facility is in the same town as Valley Hospital, so we receive from and transfer to Valley approximately 90% of our residents. Our prescribing doctors and medical director, 9 in all, are very familiar with the policies and procedures in place at Valley Hospital. In early 2016, approximately 12 of our nursing leadership and staff attended an antibiotic stewardship seminar presentation by Dr. Gaffin, Valley's lead infectious disease physician. Since then, the corporate clinical nurse has been working with both Van Dyke facilities to formalize an antibiotic stewardship program. My facility also hired Dr. Gaffin to work with us as an infectious disease consultant in May of this year. He has been informed of every antibiotic start or new admission on antibiotics since he was hired. Within 48 to 72 hours, he reviews the medical record and discusses the case and the critical information related to antibiotic need with the ordering physician. Currently, our team does not include the pharmacy consultant. However, we hope to include her as an active member next month. Van Dyke is still in the process of introducing its new antibiotic stewardship program to its staff, physicians, residents, and families. When our medical director heard that Valley Hospital was training its staff on antibiotic stewardship, he shared the information with us. Our administrator and DON, myself, and several of our nursing unit managers attended the seminar. Van Dyke has never had a lot of antibiotic usage, even though we have a lot of high acuity residents being transferred into our subacute units. But it was important that staff stay informed. It was not until this year that we really started talking about and planning for an antibiotic stewardship program. After February, the corporate clinical nurse started working on policy development with our facility and the infection preventionist from the other Van Dyke facility. She also introduced the utilization of MEADOWVIEW criteria in defining and categorizing infections. In March of this year, we invited our consultants to come to speak with our entire nursing staff on antibiotic resistance and antibiotic stewardship. Nights, evenings, and first shift participated. Then in May, we had our first formal antibiotic stewardship program committee meeting. Since May, we have formalized the program with a written policy, the use of MEADOWVIEW criteria on all possible infections, and performed numerous staff and services. Additionally, I have incorporated antibiotic stewardship into discussions during my daily rounds with the unit managers and the facility director of nursing. We are all encouraging the nursing staff to follow the new procedures regarding antibiotic therapy starts by discussing the McGear criteria with physicians, especially if the requirements for classification as an infection are not met. I try to always share pertinent research findings and answers any of their questions, no matter how many times I may have addressed the same issue in the past. I understand this process is new and staff needs time to understand its critical importance to implement as envisioned in management and the stewardship program teams meetings. Additionally, we plan to educate all our prescribers and family members in the next month or two as well. Thank you.
Thank you, Lynn. Our next speaker will be Kathleen Larvison from Meadowview Nursing and Rehab. Kathy?
Yes, good afternoon. I'm Kathleen Larvison, the Infection Preventionist, Employee Health, and Staff Development Coordinator at Meadowview Nursing and Rehab. Meadowview is the Atlantic County nursing home with 180 licensed beds, 30 of which are subacute. We are very fortunate to have an ID physician as our medical director. And along with myself as the major champion, we have shared the lead in getting the Antibiotic Stewardship Program implemented. We were lucky enough to have our ICAR assessment performed in October of 2016, where they reinforced the need to develop the Antibiotic Stewardship Program and shared the CDC's resources with us. It was important for us to hit the ground running. We didn't want to recreate the wheel by doing research and going to the basic things. So we wanted to utilize the research and best practices that experts in the field had already put together. So we stuck pretty close to the CDC's recommendations. We have a robust multidisciplinary team. The inclusion of the unit managers and nursing supervisors was important to us to make sure that we had always at least one member of the team available to help with interpretation, guidance, and support that the staff needed during the implementation process. Additionally, we added our environmental service manager in an ad hoc capacity. Though there was a significant amount of planning, background discussion, and reading of available resources, our first formal team meeting did not occur until April of this year. In preparation for the team's first meeting, we reviewed the CDC's core elements and were prepared to discuss them, as well as suggest possible program goals. By May, we had drafted a policy to be presented to the Board of Directors in June, and we established our first measurable goal, to reduce the use of antibiotic therapy related to suspected infections not meeting McGear criteria by 10% by January 1st of 2018. We also joined the New Jersey Hospital Association's Antimicrobial Stewardship Coalition and participated in their first webinar. In June, our board approved the policy and we developed our education plan. The policy included guidelines for physicians regarding decreasing antibiotic usage for residents that did not fit the McGear criteria when suspected of a UTI, as well as guidelines for our nursing staff in the SBAR format specific for suspected UTIs that would lead them to an action algorithm. The SBAR form with the action algorithm is included in the resources that you will receive after the webinar. For residents and families, we shared the CDC patient and family education materials. We posted these in the lobby and in the elevator, posted fact sheets throughout the facility, and included all the materials in the new resident assessment packet, which everyone receives dedicated to education and training of staff and our following physicians on the new guidelines. We reviewed antibiotic resistance and taught the new suspected UTI guidelines with SBAR, which our facility nurses was already using, so they were familiar with that. It focused on specific required criteria when a suspected infection is identified and emphasized prevention for the CNA by reinforcing proper pericare. We included a how-to guide on specimen collection and management when a culture was deemed necessary based on the assessment. We then added a UTI management competency for nurses and CNAs as part of their annual education initiatives. Please review our form and contact me for any additional information. Finally, we had a physician dinner meeting that dealt with our new ASP policy and the management of UTIs. The invitation came from our medical director, who is also a well-known infectious disease physician in this area. The agenda included presentations on antibiotic resistance, the rationale and guide for appropriate antibiotic use for UTIs in older adults, and lastly, I presented MEADOWVIEW's new policy, outlining the nursing protocol and the recommendations limiting antibiotic use for a possible UTI until after a CBC and urine culture results were obtained and reviewed. In addition, empiric therapy was restricted to narrow-spectrum antibiotics, Macrodantin, Bactrim, or Keflex.
Thank you, Kathy. Now we are going to hear from our third facility today, Grace Brunner. Grace?
Good afternoon. I'm Grace Brunner, the APN at the Reformed Church Home. We are a faith-based community with 108 licensed beds, and 30 of those are subacute. There is no doubt that we are much luckier than most facilities. We have 4 major champions of our ASP, as noted by the asterisks on the slide. The Director of Nursing and the Infection Preventist, Catherine, who covers the first and the second shift from a patient care management perspective, and the only 2 individuals that can prescribe to our residents, the Medical Director and myself, are employees of the facility. Both the IP and I are fairly new to the facility. The IP, Catherine, started at Reformed Church Home in 2005 and received New Jersey APEC NICE training in 2016. I started in 2014 and very quickly got started working with the medical director, looking at antibiotics prescribed for UTIs, which put us a little ahead of our ASP implementation. In 2016, our facility had several reminders to develop an ASP. First, from our ICAR assessment in June, then the CMS mandate information in September, and finally, our IP, Catherine's return from NICE training. All 4 of us started working together informally to identify an ASP team membership, write a protocol and education plan for suspect UTIs that I had been working on, and develop an ASP policy and plan. Despite all this preliminary activity, our team met formally for the first time in May with plans to meet quarterly thereafter. Our small size and limited prescribers enabled Reformed Church to implement an antibiotic stewardship program in a timely manner. We took full advantage of online courses and the NICE course held in Princeton. The IP, our DON, and myself, along with the assistant administrator, worked together to formulate a policy and implement the program within the first 6 months of 2017. From the beginning, we shared the plan via facility blast emails and encourage staff, especially nursing managers, to take part in online education. We discussed the new lab policy, CDC's core elements, and the SBAR with the staff during our daily rounds on all units. By April, we had finalized our antibiotic stewardship program policy, which we shared along with CDC core elements and the utilization of the SBAR as part of our daily discussions. Our policy's initial focus was on suspect UTIs and whether an antibiotic was necessary. With the new UTI protocol, we are not treating empirically without ensuring review of clinical symptomology and basic lab information, specifically CBC and urine analysis prior to ordering a culture. And more importantly, for our nursing staff, reinforcing the use of the SBAR and McGear criteria in the process. Each resident will be evaluated for any possible infection individually based on new onset symptomology in conjunction with past medical history. Our daily rounds became our initial training ground. We reviewed and continue to review all infections and antibiotic use daily. Our team also reviews all antibiotic use with the medical director bi-weekly and on an as-needed basis. Additionally, we have reviewed all antibiotic use since 2014, focusing on Bactrim, Macrobid, and Levaquin. Formal in-services with all nursing staff began in August, with plans to continue through September.
Thank you, Grace. And now what I would like to do is thank all of our participants today very much. I want to thank Patty, our 3 long-term care speakers, for sharing so much information with us here. And additionally, I'd like to also thank my ICAR teammates for the development and implementation of this program. We also need to thank our many state partners who have helped contribute to the collaboration between ICAR and the long-term care facilities throughout New Jersey. 2 of the organizations currently have ongoing antibiotic stewardship projects and resources that are available to long-term care facilities. The first is the New Jersey Hospital Association, who has an ongoing antibiotic stewardship collaborative for inpatient facilities. On their website, you can access all their past webinars and sign up for future webinars focused on implementing and improving antibiotic stewardship programs. Our second highlighted partner is Healthcare Quality Strategies Incorporated. This is New Jersey's QIN-QIO, who is contracted with CMS and partners with other neighboring states. Long-term care facilities have until October 31st to enroll in their Clostridium difficile program, where HQSI will help facilities enroll, report, and monitor Clostridium difficile through the NHSN, that's CDC's reporting system. This is an ideal program for facilities that are ready to start tracking and reporting outcome measures for antibiotic stewardship. However, and more importantly, it is a great way to help get enrolled into the NHSN. HQSI also has resources and webinars available on their website, including an upcoming webinar that will take place, I think it took place last week, Thursday the 21st. Although all attendees are going to receive a much more comprehensive list of resources following this webinar, we wanted to highlight 3 resources. The CDC websites listed and the AHRQ's website have some of the most useful information for guidance, to help develop and implement an antibiotic stewardship program, as I mentioned earlier in this webinar. These sites have educational webinars and toolkits for programs available. After the webinar, we will be forwarding to each of you a packet of information, including other sites, some with forms that will help you collect your data, and others with educational offerings for credits. This will also be accompanied by a short evaluation. We appreciate any help that you can give us to improve future educational offerings. And this is our second poll question. What is important to antibiotic stewardship and patient safety? So please start answering. We'll give you approximately a minute. Okay, we're closing this, and obviously this program was very, very informative because everybody got all of the above, 100%. Thank you very much for that. Okay, to start questions off, I have a question for Kathleen and one for Grace. So Kathleen, if you would you recommend to a facility to have an ICAR visit? And if you do, please highlight the antibiotic stewardship part and maybe give examples if possible.
Yes, certainly. And the ICAR assessment was really invaluable to my facility and to me in particular. I'd only been in this role for 2.5 years, and it was my first time that I have done infection prevention per se. And it helped me focus on the things that were important. And actually I was able to eliminate some things that really weren't very impactful, which freed up time for me to do other things that are more important. Initially it was like, how am I ever going to get the time to do the antimicrobial stewardship program? And the narrowing the focus of what I was doing was very helpful. The information that we received, just being steered in the right direction, getting the CDC information and having a starting place was really important. And we were able to look at the core criteria, think what's critical to start us off with, and what do we have the resources now to begin doing. The other things we could possibly wait a little bit longer. So we were able to focus on not reports. And that is also coming around to the physician. And they have been very compliant with UTIs. Our numbers are really impressive. So it was critical for us to have that ICAR assessment.
Thank you very much, Kathy. Grace, can you expand upon your ongoing education efforts that support your antibiotic stewardship program initiatives?
Yes, Carol, thank you so much. So I think here at the Reformed Church Home, the fact that we meet daily and discuss all patients on antibiotics has kind of made the staff in general a little bit more mindful of our efforts in trying to reduce antibiotic use. In addition, reviewing each case with the frontline staff nurse or primary nurse caring for the patient as issues come up I think has been a little bit more effective than a formal in-service. So I feel like here, you know, each patient, as Kathleen mentioned, being treated, you know, as an individual and not just based on lab results, the urine cultures that may or may not be colonized, has been paramount here at Reformed Church Home. Thank you.
Oh, thank you very much, Grace. Due to time constraints, I think what we're going to do is put all of the other questions, and there's about 10 more that we have, we'll put the questions and answers into a Word document and we will send it to everybody. So I want to thank you all very, very much for your participation with us today. Don't forget to look for our email with all of the resources and with those questions and answers. And at this time, this webinar has concluded.